Many thanks, Joseph Otsem, for that background report. And to begin conversation on the research in cancer and international collaboration, let me first introduce here Professor Bala Audu. He's Vice Chancellor of Federal University of Health Sciences, Azari, and Chief Convener of the Conference between the University and Sylvester Comprehensive Convening in Research and Collaboration. He's also the newly elected President of the Nigerian Medical Association. Congratulations and welcome to Good Morning Nigeria.
Thank you.
All right, also joining us here in the studio is Professor Bello Abubakar. He's of the Department of Research, Development and Innovation, Federal University of Health Sciences, Azari, Bauchi State. Thank you very much for coming.
Thank you for having me. Good morning, Nigerians.
All right, we also have with us for the conversation Professor Matthew Schulambrak. He's a professor of clinical obstetrics and gynecology and reproductive sciences. He's also the vice chair of Global and Community Health Director, Gynecologic Oncology Fellowship Division of Gynecologic Oncology Sylvester Comprehensive Cancer Center. Long list. I think I have to stop there. Many thanks for joining us for the conversation.
Thank you. Good morning.
By the way, has been your experience in Nigeria?
Absolutely amazing.
All right. So we also have with us this time, joining us via Zoom, all the way from Kano. We have Professor Sophia George, Associate Professor, Department of Obstetrics, Gynecology and Reproductive Sciences Division of Gynecologic Oncology, Associate Director, Diversity, Equity and Inclusion, Sylvester Comprehensive Cancer Center, University of Miami, Miller School of Medicine. Many thanks for joining us, Prof.
Good morning. Thank you for having me.
Okay. So let's begin this conversation by simply asking, let me direct my question to the VC and ask, where are we with the research to deal with cancer?
Well, in Nigeria, we have a lot of research work going on, many of them in silos, in hospital-based and university-based researches that have documented a lot as far as the epidemiology of various cancers are concerned. Moving forward, we need to be able to collate that data on a population-based registry, which recently the National Institute of Cancer Research took the lead to ensure that Nigeria has a robust cancer registry. And the Minister of State for Health last week actually declared that in Nigeria, cancer is now a reportable disease, which allows us to have comprehensive data on all forms of cancer in this country.
Right, and if you would say, well, the current research priorities, what are they as far as Nigeria is concerned?
The current research priorities should be directed mainly at prevention and early diagnosis of cancer. But also there's a component of the cancer treatment. And cancer affects virtually every tissue in the body. So there must be research in each and every area of cancer, ranging from gynecological cancer, hematological cancer, pediatric cancers, gastric cancers. And this conversation is currently going on because there are specialists and subspecialists in these different areas. But the ones that plague us in this country, that we seek increased research data that will enable us plan and intervene effectively, include breast cancer, cervical cancer, prostate cancer, colorectal cancer. And the beauty of this is these cancers are also preventable. But they are effective preventions only if this is carried out on a population-based approach. Unfortunately, what we have in this country at the moment is sporadic screening. And unless we move towards routine population-based screening, then we'll be able to achieve what will reduce the incidence of these cancers. And by catching these cancers at an early stage, we're also able to profile cure, particularly for cervical cancer, where the World Health Organization has declared a strategy of the 90-70-90 approach to ensure that cervical cancer is eliminated as a public health problem by the year 2030. And Nigeria is already taking a cue in this by introducing the vaccination component, which is the primary prevention strategy for cervical cancer, by ensuring that all those who are eligible for vaccination, at least 90% of them are vaccinated by the year 2030.
All right. I want to thank Professor Audu for your opening comments there. Let's quickly get to Professor Abubakar now. Listening to Professor Audu, you know, so many questions on my mind, but I'd like to begin with what the challenges are at the moment, you know, for research in cancer and the kind of cancers he's talked about that, you know, are more in Nigeria, and what kind of international collaboration is Nigeria seeking, you know, to be able to get deeper into the research and be able to handle it.
Well, thank you very much. First and foremost, Professor Audu has made it very clear that most of our researches are in silos. In other words, people are doing research in different parts of the country, but it's not systemic. It is not properly institutionalized. And so clinicians tend to get engaged in research for different type of cancers. But we don't have a national concerted effort to do a strategic research. For example, let me give you an example of the liver cancer. We know that one of the real causes of liver cancer is the hepatitis virus. Now, how much of hepatitis virus do we have in this country? We don't know. We haven't done any research around that. We will want to know, we want to have a national program on screening of the hepatitis virus, hepatitis B and C. You know, it was the number one cancer in Egypt, but they were able to screen over 60 million people, and that brought down the prevalence of liver cancer by almost 80%. So that is a concerted, planned research, and this is the kind of research that we'll want to see also in Nigeria. The kind of the human papilloma virus that is responsible for cervical cancer is defined in many parts of the world, but how much of those strains that cause the liver cervical cancer are really prevalent in our environment? Do we have other strains that are really not covered, for example, by the vaccine? So these are kind of national planned research that we'll also want to see. So in that vein, I mean, a lot of work has been done around the globe, and most of the institutions that are involved in collaboration must have had one form of research in this direction to be able to guide us. So we are not inventing the wheel, but we want to have those data in our environment in Nigeria to be able to say, yes, this is the prevalence and this is the strategy we are going to use to mitigate it. The idea of research anywhere in the world is to be able to have proper data for that environment that will determine the kind of outcome that you will be expecting as a result of those research that you have done. If, for instance, we are trying to eliminate cervical cancer, right, and we are giving the human papilloma virus vaccines, and we know that what Nigeria is using is the quadrivalent vaccine. That means it covers 4 strains of the human papilloma virus. But there are other oncogenic viruses, those that are also going to cause cancer, right? That's why they are called oncogenic. So we'll want to know how many of those are really in Nigeria that are not really covered. We don't have that data. And it may surprise us, perhaps, that we will have more of those viruses that will cause cancer that are not covered on this vaccine. Even though it's a global thing, but it's statistical deduction that yes, strain 11 and 16 are the real culprit, or 18 as it were are the real culprit, but there are others. So that kind of research is the one that we want to see. And I'm happy to note that the newly formed National Cancer Institute for Research and Treatment is also trying to collaborate with us at the Federal University of Health Sciences to see how we can develop some national questions, national hypotheses around these things to drive the research that will be of national interest.
Okay, let me get to, I hope I get this right now, I have to, Professor Schlumbrecht. Thank you. So, maybe I should ask, I have a sense of what has brought you to Nigeria, but how is it going? How is international collaboration, such as the one you bring to Nigeria, helping to advance research in cancer in Nigeria?
So I came from the perspective of living in Miami, which has a very diverse population with a significant number of Afro-Caribbean women and African Americans. And so on the most basic level, I have these patients who talk to me and have questions about their cancer, and we don't understand, and I can't provide them the data because unfortunately women of African descent have been either excluded or not included in a lot of the clinical research that has been done in the field of cancer across a number of disease sites. We often say global is local and local is global. So what we can learn from our colleagues in Nigeria will help us back in the US, and what we can bring in terms of expertise will also help women here in Nigeria. I've had a long-standing collaboration with the International Gynecologic Cancer Society, and I serve on their global fellowship program. And so what we've done since 2018 is develop these international training programs in gynecologic cancer. And so we have several trainees here in Nigeria who participate in what we call tumor boards. So these are monthly meetings to discuss challenging cases. We use it as an educational tool. I've come to Nigeria several times to do surgical teaching. We're actually in the operating theater yesterday, treating a patient with cervical cancer. And so it's this kind of bidirectionality that's really going to allow us to enhance clinical care here, but also to better understand disease pathogenesis, some of the genetic drivers of disease, so that, as Prof. Bala had mentioned, identify very early on where we can intervene to either prevent disease or to find it when it's still very early.
All right, thank you very much, Professor Schlumbrecht. We'll get back to you, but let's head to Kano now, where Professor Sophia George joins us via Zoom. Reading the profile of the guest here and reading a bit about cancer research, I want to find out how will international collaboration actually enhance the capacity of Nigerian researchers. Professor Bello Abubakar was talking about some of the challenges and then the data and all of that's happening, and then people having their individual research, no national coordination in all of this. So how would this assist Nigerian researchers and healthcare professionals to conduct high quality cancer research and produce evidence-based care?
Yes, so good morning. What we have done is leverage our ability to do both clinical and basic science research. to collaborate and work with our colleagues here, I'm in the North right now, to build infrastructure, both for data science capture, also protocol development, so that when research is being done here, that it is done with the highest integrity in the context of the infrastructure that we're doing, the data type of data that we're collecting, so that we can make better inferences from what the data tells us. And so for us, our collaboration includes, like as Dr. Schoenberg said, bidirectionality, learning also from our colleagues here in Azare and in Kano, from Prof. Bala and Prof. Bello. And so we hope that it's learning on both sides, learning about our populations on both sides, and then being able to share data in a protected way, actually. And so we've come with data scientists here to be able to, again, bidirectional collaboration in building data systems, in looking at the data that we've collected collaboratively and also independently, so that when we make conclusions, that they're conclusions based on like really strong data.
Thank you very much, Professor George. Let me get back here in the studio with Professor Mohammed Audu. What challenges are there? You know, what are the stumbling blocks to researching into cancer in Nigeria?
The greatest challenging blocks are getting the modern, up-to-date equipment that are needed to study cancer at the molecular level, as well as the training and retraining of the highly skilled manpower that is needed to carry out these investigations and to interpret the results of these investigations. With equipment also comes the consumables in terms of gene probes, especially for genetic studies and molecular studies, that are needed to carry out these studies over time. I'll give you, for example, we have a grant from TED Fund, the NRF grant. We won to study megagenomics of ovarian and cervical cancer as a comparison, and to see if these megagenomics, by understanding them, we can improve treatment outcomes, because the bacterial, the microbial microenvironment of the cancer itself may affect how patients respond to treatment. However, the cost of doing one sample can be so prohibitive, especially at this time in our economy, when we look at the conversion of the naira to the dollar, especially since virtually all these reagents have to come from outside this country. And this brings to value the kind of international collaboration we're having with the University of Miami. And we are leveraging this relationship to do these investigations with them. And we have applied for tissue transfer between our institution and their institution to be able to carry out these investigations out there. And that is why we're talking about capacity building. With the coming in of the institutions like NICRAT, we believe we'll be able to develop those infrastructure in this country and be able to support the equipment base that is needed, as well as provide the consumables for us to be able to carry out such researches directly in this country and still leverage on the international collaborations we have. It also gives advantage to have this kind of international collaboration because there is diversity. For example, at the early stage of our collaboration, we studied the pattern of ovarian cancers we see in this country. It was a very large study that involved 22 different centers in this country, and we compared that data with what is seen among Afro-Americans in the United States as well as African Caribbeans. And there was quite a significant difference. What seemed rare over there was relatively common here. And we now are trying to define why, for instance, we have more germ cell tumors of the ovary in this part of the world compared to what they see there, and whether there are genetic differences and even response to treatment. In addition, part of what we discussed at this convening is a clinical trial that comes from the United States that is being carried out by the University of Miami at the Ahmadu Bello University Teaching Hospital on the use of PAP inhibitors in the treatment of ovarian cancer. These are drugs that are already in use and approved by FCDA in the United States. But like Professor Matt Stromberg mentioned, there is a paucity of testing and clinical trial amongst blacks, even in the United States. And bringing this kind of study to this country helps us leverage to see how these drugs can effectively be used in our population. Even though these drugs are very expensive, but our patients also stand the advantage of getting these drugs free during that period of clinical trial. So it brings in a lot of advantages. We see the challenges, and the essence of challenges is to find ways of overcoming these challenges. And that is what we are doing.
Okay, talking about overcoming challenges, we've had programs on this station, on this program, Good Morning Nigeria, about cancer. And you also pointed it out in your initial comments, talking about early diagnosis of cancer as being a major challenge. Now, with this research, help to address that problem. I'm asking that because we know a lot of people who have gone on to die or suffer complications as a result of cancer, not necessarily really based on the fact that early diagnosis wasn't done. Would you want to put that challenge on research or on manpower or on infrastructure?
It's a combination of a number of factors. It's a combination mainly to do early diagnosis. You have to screen the population. And that is why I talked about routine screening that is population-based. What we have currently, and let me use particularly those cancers that WHO have identified as cancers that should be screened routinely using specific guidelines, include breast cancer, cervical cancer, prostate cancer, colorectal cancer. Let me use the case of cervical cancer. Screening for cervical cancer generally is said should begin at about at least the age of around 35. Lower age for us here in this country, 30. And what are we really screening for? That is outside of vaccination, which is a primary prevention. Screening is a secondary preventive measure that allows you to identify those that first are at risk of developing the disease, because you can identify that they carry high-risk human papilloma virus. But many of them will clear it. Okay? Then, during that procedure, you are also able to identify if they have high-risk human papillomavirus. Then you now look at the cells on the surface of the cervix. So you do what's called a pap smear, or you do any of the other related investigations that identify whether they have precursor lesions. These are changes in the cells that indicate that if this is allowed to continue over time, it will develop into cancer. Now, there is cost to that. And we all know that in this country, health, most of us pay for health out of pocket. And that is a great limitation. So if we're able to provide through the National Cancer Fund for screening, then a large number of the population will now take advantage of that and come for screening. Now, during screening, like I said, when you see those precursor lesions, then you intervene. So there's no point that you screen and you cannot intervene and you cannot treat. In this country, we do the pap smear. We also do what is called visual inspection with acetic acid. And with that, once we see the lesion, we actually treat instantly. But for it to be impactful, it must be done routinely and population-based, not sporadic. Sporadic means patients come, for instance, to the gynecological clinic for other reasons like family planning and so on, and you take that opportunity. So you see, you're just looking at a very minimal infinitesimal proportion of the population. Now, once you're doing that routinely, then you are also able to catch what is called early disease. It's called early disease because it's asymptomatic. It is so early, it has started at the levels of the cell beginning to change to cancer. But it does not cause any problem. You don't feel anything. So you don't even have a complaint. But when you look under the microscope, you're able to see those cancerous changes have already started. And when you catch it early, you can actually treat it, and not just treat it, you cure it. Once it goes beyond what is called early disease, it's not curable. You can treat, but you do not achieve cure. So the essence of screening is to prevent its development to cancer, and then to catch cancer of the cervix at an early stage and cure it. Okay? So you see, the mitigating factors really are infrastructure, cost, all right, and recurrent cost, as well as, of course, the skilled manpower, particularly at this stage of our history in the health sector, where we have a significant proportion of our healthcare providers emigrating out of this country, which is a different conversation for another day.
All right. Thank you very much, Professor Audu. I was going to ask, I know someone who was very close who had cervical cancer and got cured. And that was because they said, well, it showed up early, the doctors became aware early, treatment commenced early, and there was cure. But these days when you hear that someone has, in fact, most forms of cancer, it's almost like a death sentence. Now, at the moment, if Professor Audu is saying, well, we have to do population-based screening, while we are unable to achieve population-based screening well at the moment, what else can be done to be able to achieve early diagnosis and then be able to cure? Yes.
Thank you so much. It is not impossible, really, to have population-based screening in this country. Why? Because the Federal Ministry of Health has developed a program, the National Comprehensive Cancer Program. And in that cancer program, in that document, there is screening for all the main cancers, the most prevalent ones that he has enumerated: breast cancer, cervical cancer, and prostate cancer. The only problem that we have there is costing. Is where do we get the money to unleash it? And we have to, one way or the other, because no country can survive without institutionalized national screening programs. But while that is ongoing, education is very critical. And that is why we have a lot of advocates around the country that have been educating people to go and get screened. If we are able to convince average Nigerians that screening is very fundamental and it can prevent you, it can save your life, then I want to believe that we are going to make a lot of changes. But education is very critical. Awareness is very critical. Acceptance is also very critical. Nigerians must accept also that screening is fundamental. Screening is the way to go to prevent, excuse me, to prevent late diseases. We do know that 86% of our patients present at stage 3 and 4. But that narrative can change with a lot of education and a lot of convincing as well. Because when the vaccine for the human papilloma virus was launched, a lot of people were shying away because they felt there were this, fake news that is going to cause infertility, is going to do this and that. And the National Primary Healthcare Development Agency had to, reach out to opinion leaders, to our fathers, royal fathers, our clerics, and so on, to start talking to our people that this is not true and this is very critical. And with that, a lot of people came up. I was happy to note that in my state, the uptake was over 86%, which is so fantastic, I came from Bauchi State, right? So if we are able to convince people to take vaccine, we may as well try as much as possible to convince people to go for screening. You'll be surprised that in this NTA today, if you take a quick survey, how many men above the age of 40 have gone to do a PSA test for prostate cancer? You'll be surprised that it's less than 10%. And yet this thing keeps going on and on. So we need to educate and re-educate our people, and also to convince them, because it is one thing to talk to them and it's another to convince them to go and do those screenings. The screenings are readily available in this country. You will not go to any major city where you cannot get pap smear or VIA or mammography or a PSA test, which is a simple blood test, okay, that can save many Africans' lives, because prostate cancer is the #1 disease of Africans and people of African descent. And it's something that you can actually pick early and treat early to prevent all the possible complications that come with it. But because people are still not convinced that it is critical to go and do those tests, the PSA, the pap smear, the mammography, that is why we keep getting people at the age of, at late stage.
All right,
we still believe it's not my portion. I reject it. So people don't save money for rainy days for their health care. When people receive salaries, they have small money that is for fuel, for repair of their vehicles, but they don't save anything for their own house. And that is why they always don't want to go and do basic things until it is really late.
You know, Professor Abubakar, talking about being really late and your comment about the fact that most cancer patients present at the third and fourth stage, not all of those patients actually shy away from health facilities at the early stages of that ailment. Sometimes it is the inability of medical professionals to diagnose exactly, correctly at the initial stages of such ailments. That's why I try to ask about infrastructure. We know about the primary health care centers. We know about secondary, tertiary medical facilities and all of that. But there are some medical centers you get to today in this country that, I mean, they don't do all of this. So when you present, they are treating malaria, fever, and the rest, and it is when all of those treatments fail that you get referred somewhere else where it is eventually discovered that you're dealing with cancer, and at that stage it becomes too late. So I want you to speak around that. The fact that what you're saying, the screening and the rest is not available everywhere. That's one. Then two, talking about vaccination. I'm glad that you mentioned it because I had it in my mind to ask. There's this conspiracy theory about vaccinations, not just about the HPV vaccine, about vaccinations in general. That there's this saying, there's this thing going around town about the fact that it's a plan by the West to do this to the African population. Speak about that, in as much as I also want Professor Matthew to talk about it too.
Okay, so what I said, I want to repeat that again, is that there is no any urban center in this country where you cannot get screening. That's what I said. Now, what the Federal Ministry of Health is doing now is to really develop the national, the primary clinics around the country, the primary health care clinics, such a way that they will be able to do basic investigations such as screening for cervical cancer. And the coordinating minister of health is very specific about this, that they are trying to make sure that the primary health care is properly and fully developed, that they are able to do able to do screenings. And this is ongoing. They have started with about 7,500, I think, primary health care, where they are really developing them, and very soon they should be able to. Yes, I totally agree with you that some clinicians, don't consider cancer as part of their differentials when they are seeing their patients. And that is changing through education. We are doing a lot of education and retraining of clinicians as well, so that they will recognize that cancer is a very important differentials, so that when you are treating somebody that has epigastric pain, persistent, and you think it is ulcer, and it has not been cured, after the first treatment, second treatment, you need to start thinking of other differentials, such as gastric cancer, such as pancreatic cancer, and then refer them to the appropriate hospitals. It is not right that in the primary institutions you will treat cancers. Most cancers are treated in tertiary institutions, and that is where the problem is. And so those that are working in the secondary institutions have not taken advantage of all the differentials that they have. We have developed also a desktop manual at the Federal Ministry of Health that will educate or remind rather clinicians that are practicing in the secondary institutions, the general hospitals, and I think is being distributed free of charge. That will remind them, because they work so hard. They are very few. Majority of the people have left the shores of this country, and we're having a deficit. It's one country. Nigeria is one of the few countries that we don't look at the doctors-patient ratio. So if 20 of us are working in this place, and within 1 month, 10 of us have left, nobody is worried that we need to replace them. The burden of that work continues with the remaining 10 doctors. And that is why a lot of doctors are in a hurry. They are in a hurry to treat patients. So they are not very thorough. But they are still working very hard. And I want to assure you that the Federal Ministry of Health, I'm not a spokesperson for them, but from what I have seen going on now with the new Minister of Health, a lot is being done to change that narrative.
Okay.
And of course, maybe he will talk about the conspiracy theory, but we have been talking. There was this conspiracy theory that was really, really hot in Abuja about last year, toward the end of last year, around the human papilloma virus. And it was even discussed on one program called Berkete Family. And so many people had to go and educate those people that think that it is used, to reduce the fertility of people.
All right. Professor Bello, thank you. Thank you very much. While you have invited Professor Schlombert to talk about the conspiracy theory, let me add to it. How close is humanity to finding vaccine for cancer?
That's a good question. So I'll talk about the conspiracy theories first.
Oh, don't have a lot of time.
I'll go very quickly. Those things are universal, unfortunately. We see that in the United States as well. Although the narrative is a little bit different. In the US, people think vaccines cause autism, or that the human papillomavirus vaccine causes promiscuity. And there have been some very good data to show that it does not do that. It doesn't increase teenage pregnancy rates. It actually facilitates a dialogue about contraception and sexually transmitted infections and things like that. So I think recognizing the patient's concern and acknowledging that, but then utilizing the tools that you have to educate them, utilizing community leaders, faith leaders, thought leaders, I think that's a very good approach. In terms of, is there a vaccine for cancer cure? Every single cancer is different, and the genetics of each cancer is different. I think that there are going to be some cancers, things that are mediated by viruses, like we've been talking about with the HPV, that could be cured by a vaccine. But I think that in terms of prevention, we need to think a little bit outside of the box about what constitutes increased risk, and think about things even including risk-reducing surgery. So if somebody has a genetic condition that would put them at very high risk for ovarian cancer, there are guidelines to remove their ovaries at the completion of childbearing, because we can reduce that risk by 90%. When we are looking at some of the novel treatments, though, we have a lot of opportunity for cure even if people get cancer. So while chemotherapy has been the backbone of treatment for decades, as we move into the new era, we have things like cancer vaccines, so vaccines for people who actually have cancer. We have immunotherapies. We have what are called new targeted therapies. And what those things do is they directly impact the cancer cell and interfere how it communicates within itself. So the the clinical trial that Prof. Bala was mentioning earlier utilizes PARP inhibitors that in some patients, even if they present at stage 3 or 4, can end up being curative. And so we need to look at cancer treatment as a continuum, not just kind of primary prevention and screening, but also what can we do to enhance the research kind of globally to make sure that the treatments that we're coming up with are highly effective.
All right, thank you, Professor Schlombert. Of course, interesting to note that even in the U.S., there are conspiracy theories about vaccines too. It's important that Nigerians hear that, Africans hear that too, just so that, they can be at home with vaccines and save our lives. I'd like to get to Professor Sophia George now. So much about cancer now. The numbers are increasing by the day. Could you, just speak to us about what is responsible for the increased number of people coming down with cancer, and just speak around it. Is it lifestyle? Is it I don't know, everything now is being blamed on global warming? So speak to us about that.
Sure. So there, beyond genetics, which is a stable factor, there are other factors like, as you said, lifestyle. And what we mean by lifestyle includes diet, exercise, of course, smoking, alcohol consumption, and there's also environments like air pollution and so on. But these four, so diet, exercise, smoking, and alcohol consumption, are responsible for at least 17 types of cancers in terms of the excess. And so, even if I'm a molecular geneticist, we also talk about how we can mediate and smoking, which we know are triggers for increasing your risk for cancer.
What are the opportunities and challenges, of international collaboration in cancer research and care in Nigeria, and how can we strike a balance between, local empowerment and that global cooperation?
The advantage we have and the focus we're directing our collaboration is to understand and ask our own local questions that will explain what we see in our own environment, and to build our own capacity to be able to do clinical trials that check the efficacy and safety of the cancer drugs that we use in this country within our own population, and to compare this with the differences that could exist between us and what is observed in other parts of the world amongst blacks in the diaspora and also amongst Caucasians. And this will give us an insight on how to modulate our own treatment and the treatment difference that we need to put in place to get better outcomes when we intervene in our own population. Because it has been shown both incidence as well as how cancers progress amongst different populations is different. And even in terms of response to treatment, there are differences to response to treatment. And these are the questions we want to ask on our own side and profile solutions to them so that our interventions are more effective and produce results that are in the range of best international practices.
In terms of proffering solutions, are you looking at homegrown solutions? Such that I know you have international collaboration. We have most of the medication and all that you're using, not just for cancer but for other ailments in the country. Medical professionals like you would prefer to import the drugs and all of that. But we've also had people talk about alternative medicine. Talking about the Nigerian society being filled with all kinds of medicines that we have and all that. So are you looking in that direction too in your research, such that we are not totally dependent on the outside world in dealing with cancer?
Well, these are aspects that our research can also progress into, which I must say at the moment are not the immediate things on our table, because there are more fundamental issues. Currently, we're leveraging on what already exists internationally. Yes, we can also leverage, and this will depend on how robust response we get from our pharmaceutical manufacturing sector of this country in terms of producing generic drugs that can be used in treating cancer. Of course, we can also research into alternative medicine. The Medical and Dental Council of Nigeria still regulates alternative medicine practice in this country, and we can definitely research into our local herbal medications. But as you know, this needs to be properly regulated, properly tested, and adequate clinical trial carried out to ensure that they are both effective efficacious, and safe.
All right. Thank you very much. Let me quickly, we have just a few minutes to go. There's a couple of minutes. So maybe in 1 minute, Professor Bello will be able to tell us if these international partnerships are facilitating, the transfer of technology and expertise in cancer diagnosis and treatment here in Nigeria.
Yes, I absolutely agree. Yes, they are. Not only that, they are also encouraging best clinical practice that is done globally. There is always learning. He has mentioned the tumor boards that we are talking about, where, hospitals interact with different parts of the world to see whether their practice, is actually in tandem with the rest of the world. So that is very critical, and this is one of the things that we are always encouraging, because it is the low-hanging fruit. You discuss with your colleagues on patients' care to know whether you are really doing the right thing or not. That helps you a lot. And Nigeria is not an exception. It's a global village as well, where whatever you are doing here may have an impact on another part of the world. So yes, international collaboration is really supporting what we are doing here, and it will only get better outcome for our patients.
All right, because of time, we'll have to leave the conversation at that point. Many thanks, Professor Bala Mohammed Audu, Vice Chancellor of Federal University of Health Sciences, Azare, and Chief Convener of the conference between the university and Silver Star Comprehensive Convening in Research and Collaboration, and of Cancer Center and Research. All right, thank you so much. And of course, the newly elected president, Nigerian Medical Association. Many thanks for joining us, Professor Audu.
Thank you for having me.
By the way, you need to tell us the venue for the celebration. All right. We also like to appreciate Professor Bala Abubakar from the Department of Research, Development and Innovation, Federal University of Health Sciences, Azare, Bauchi State. Thank you so much for joining us.
Thank you for having me.
Okay, and yes, Professor Matthew Schullenbach, Professor of Clinical Obstetrics, Gynecology and Reproductive Sciences. I'll have to stop there because of time. It's a long list, Thank you so much for joining us. And of course, we want to see more of you in Nigeria.
I'll be back soon.
All right, thank you. And yes, Professor Sophia George, Associate Professor, Department of Obstetrics, Gynecology and Reproductive Sciences, Division of Gynecological Oncology. Thank you so much. I'd also have to stop there. Thank you so much for joining us for the conversation, ma'am. All right, so we'll take a break now. When we come back again,